Thanks for coming to see a historian. This paper started in a demography seminar I taught, and J. Meg Carbia was a student there, came to me with this idea of a project where she was interested in systemic racism and its impact on child mortality in the past, which I was thrilled about, but I was a little skeptical. I wasn't sure how you measure systemic racism in the past. With dealing with historical data, it's always, it's not a variable in the census. And she brought up the idea of residential segregation, and I was still skeptical because, as I'll explain in a few minutes here, my perception, at least at the time, was that there wasn't much racial residential segregation in the past, that it is in fact engendered by the Great Migration that begins in the 1830s and 40s. And my sense was it couldn't explain much, kind of thing. So I became a little skeptical, and I became a believer at some point, and I was involved in the measurement of mortality and segregation. It was kind of a challenge. It's always a challenge with historical demography. I love it for that reason. J. Mag is a co-author, so I just wanted to acknowledge her lead role on this particular case. Let's see. And there is the first button press. Click here first, and then, yes, of course, it's intuitive. So, quick overview of this paper. It's a very simple paper in some ways. We are going to estimate child mortality for Black and white population in the 5 years before the 1900 and 1910 censuses. And the reason for that is that these two censuses have some unique questions that allow us to measure child mortality. Normally, censuses are censuses of the living population, right? These particular two censuses, we can measure dead children. And we also use the census to construct our measures of residential segregation. We're looking at both urban and rural areas. This is a population that is 90% rural. So, and there's relatively little urbanization in the South. So, and then we're going to model logistic regression, the impact of, or the association between segregation and children's mortality. That will not be too exciting. There's not going to be really interesting, great causal designs here. The challenge in this paper is the first two here, measuring child mortality, measuring segregation. And I'll take questions at any time. I don't mind being interrupted. So if you have something, you're probably, people sitting next to you will appreciate it too, right? Any right now? Okay. Let me just start with some data considerations. I said the challenge, it might be measurement here, historical data. And in the United States in particular, this classic federal state issue that we still bedevils this all the time, is also in the 19th century. Vital registration was left to the states. So where England and Australia have vital registration systems from the 1830s, the US is really late getting in the game. A few states, Massachusetts gets involved in 1840s, but as late as 1900, when the federal government steps in and says, we want to create a national system of death registration, there are only 10 states out of the, 45 at this time, some territories, that had systems that were considered complete enough to enter the system. And by complete, they think that 95% of the deaths had been registered at that time. And these are not a representative sampling of states because they're almost entirely in the Northeast. Only Maryland is the only southern state included in these early death registration states. And just get some sense of the issues here, those states in the death registration system only cover 4% of the nation's Black population. And the Black population that is covered is northern, and it's 80% rural, whereas the Black population overall is less than 20%, it's 80% urban covered in the DRA. And in fact, it's just the opposite. It's only 20% nationally. So very unrepresentative slice in the death registration area. Birth registration starts even later. Both of these systems are deemed to be complete in 1933 with Texas is entered in the system, but they were just kind of pushing Texas in because it was last and it was deficient registration for some time. So the ironic part for me as a historical demographer is we consider like 1933 is like the low point in fertility. The fertility transition is over. 150 years of some of the most amazing early decline in the world is not documented until the last year, in a sense, right? So this kind of drives us into, well, drives us batty, but into other types of estimation. That's the vital registration side. What we do have is a census, and it begins in 1790. You know this, I'm sure. It's required by the Constitution to apportion the Congress. And from the very beginning, although they only needed for the Constitution to know the number of free and not free individuals, slaves, they collected more. They wanted to know more. And every year added a little bit more information. Household level collection from 1790 to 1840. But there's a real marked change in 1850 for us. And this is the first year we have individual level registration. So there's a line on the census form for every individual. So everyone's named, age, and various types of characteristics recorded. The census office is part-time. It comes into being every it's kind of an ad hoc thing. And they publish a few volumes and it goes away again until 1902 when the Census Bureau becomes a permanent institution. They're publishing aggregate statistics every year, but they're really following behind in a big way. It's really difficult to take 50 million cases and hand count them. You know, there's an army of clerks in DC and they're working for years just to tell you how many people, shipbuilders there are in the state of, Maryland. And so you get really kind of coarse aggregate statistics. And it's a shame because there's a lot of detail. Some information is not even tabulated. And in fact, the children ever born, children surviving, I'm going to show in just a minute, was never tabulated. It was collected, but never tabulated. Address information is collected for cities beginning, they asked for it beginning in 1880. There's very few cities, and most people don't record it. So in terms of being able to geocode this data, it's really, really limited. So I've just convinced you not to become historical demographers, but there's going to be some good reasons coming why you want to consider your next project to be. And I'm going to step out a little bit and just say something about some of the positives here. Data is not geocoded, but there's a really interesting thing going on until, I think it's 1960. I was telling someone 1910's current events for me. 1960s, the first mail-in census, I think. And up to that point, census enumerators went door to door collecting the census. And even though they might not have recorded an address, many people didn't have them, is the order of enumeration establishes typical travel paths between households. So if you have people next to each other on the enumeration form, you're pretty sure they live next door to each other. Not always, but at least very damn close, right? So we're going to use that in our measure of segregation. We're going to use microdata. And I just want to, since I'm here, I'm going to step out of the paper and just evangelize for a moment. You're being preached to about the IPMs. I'm not even going to apologize for that. The original manuscript returns for all these censuses survive. Few from 1790 don't, but 1890 census caught fire, is gone, unfortunately. But those returns have been digitized first in what were called low sample density public use samples, PUSs. Probably many of you have already heard this. A little local history for you. The Census Bureau created the first public use sample in 1960 census, and then they did it in 1970 as well. And here at Wisconsin, Hal Winsborough gets the first NIH Population Center grant and also buys an IBM 370 to process these public use samples of the 1960 and 1970 censuses for the low price of $475,000, about $3 million in 2022. I was going to look it up how much more memory my phone has than that. But I assume it's in one of these rooms here. Was this building here in 1972? It's on 4th floor? Okay. They have the old computer flooring kind of stuff. Okay, still the server room. Anyways, public use history happening right under my feet. 1940 and 1950 census, this is the first historical project that's kind of a major grant. Talk about a major grant. Winsboro gets $7.4 million from NSF. That's $27 million and 2015 dollars to construct what are 1 in 100 random samples of the 1940 and 1950 census. They actually had to contract out with the Census Bureau. And what these samples are is they randomly pick 1 in 100 households. Someone types it in, right? They didn't type in names at the time, and these data were made available on tapes for people to do research. So a little local history there. That was 1984. Following Winsboro, Sam Preston took up the kind of mantle for historical censuses and collected samples for 1900 and 1910. They were lower density, 1 in 750 sample density samples. And he was doing that because of these questions I'm about to show you on children ever born and children surviving that made for some interesting analyses. And then Steve Ruggles at Minnesota started writing grants. I think 1880 was the first grant Steve wrote and gathered. And we've been producing at Minnesota then public use samples, IPMs we would call them. That's the way we pronounce it. They're integrated in the sense that the coding is the same census to census, which makes easier using. That's Ruggles there. That's what I looked like 30 years ago. So I still bald. I can't even go back 30 years and find a picture with hair. Sample density varied quite a bit, but typically about 1 in 100 samples, sample density. And what that meant is that if you wanted to, let's say, study a small place, let's say Madison, you probably wouldn't have enough cases in the sample to do kind of local geographic analysis. You certainly couldn't do segregation measures that I'm going to show you in a bit here. So they were really valuable. You could make your own tabulations. You could create models. There's a lot of research has been published. I think it's one of the most used social science databases in the world. Really useful for the type of analyses we do, but still limited in some ways. Am I talking to everybody that's used the IPMs a little bit here? Yeah, okay. Sorry. I'm going to evangelize anyways. What's happened in the last few years, though, is I think really fascinating, is that with private genealogical companies, this is Ancestry.com and Family Search, has typed in everybody. They digitized the whole thing, every census, every individual record, and we've kind of partnered with them, and they provided that data for us. So now we call these complete count. I guess they're no longer samples, they're populations. And we have microdata, individual level data on everybody who was enumerated by the census. The 1850 to 1880 project, I put it in bold because I just finished that. I was PI on that project. But 1950 we got last week. Ancestry sent it to us. So we are busy trying to get data out on the web for people who want to use it. No promises right here, but people are working furiously to get it out now. So some 824 million records. It is just a massively great resource. I want to encourage you to think about using it in your research. And it gets better because we have this grant here, which we're calling a multi-generational longitudinal panel data set, where we're taking these complete count data sets, which includes names, and automatically using kind of nominal algorithms, finding people in the subsequent census and linking to them. And those crosswalks are available on the web now. This is all public information, by the way, public data. So you can produce kind of multi-generational samples. You can follow people over time. It opens up a whole new area for research. And I guess it's a great time to be a historical demographer. But there aren't many of us. I mean, I would encourage you to get into it. There are challenges, which you'll see in a minute here, of data, and there's not a lot of people going to read your work, perhaps. But there's some fabulous stuff that can be done. There's some low-hanging fruit, some big questions, I think. And I could just throw out, early fertility transition, they're one of the earliest in the world. Immigrants. This is in some ways a great laboratory for social science theory because we have a very diverse population, documented over 100 years of incredible economic and social change. And just if you have a hypothesis, here's your data kind of thing. Okay. All right, I'm going to give you one application of this, and back again to the paper. So apologies for that step out. Any questions about data, IPMs? Yeah.
So I'm looking at this original asset. So from what years again, the multi-generational?
Right now, we're just linking each year to the next subsequent. And oh yeah, it's publicly available. We're constantly revising, of course. There are a few limitations early on. We can't link slaves because they're not named so the Black population really doesn't start linking until 1870 to 1880. But we're linking about 30% of individuals or something like this. There's a lot of people we just can't determine. We want to minimize kind of type 1 errors. We don't want to identify someone as a link that is not linked. So we're kind of, if you have a common name and birthplace, like is born in New York and your name's John Smith, you won't be linked. Yeah. Yes, free Blacks can be linked. Exactly. We do have microdata on the slave population, but no names or linking across time. Someone else, yeah. Puerto Rico 1910 is not longitudinally linked, but we do have microdata on it. Yes. Yeah. Yeah. That's the one that burned up. It's destroyed. The original manuscripts were destroyed. So I've been talking to Steve. We think we should hot deck the whole thing. We just borrow people from 1900, borrow some 1880, age them up 10 years. We know the counties. We know the county stats. There needs to be 322 farmers in that county, and you could just keep swapping people in and out until as you improve your match. And so we can kind of hot deck a whole population in 1890. I love the idea, and then your graphs will chart across. You can download IPMS data, you run your crosstabs, and you always get that damn gap. And it's right at a critical moment too, and so at least I think so. 19th century. Was there any other questions? I'm sorry. Did I step on someone? Okay, let's get into the project then. I'm not going to be doing all that. This again, estimate child mortality, try to estimate segregation measures, and look at the relationship between segregation and children's mortality. Some motivating questions here. I guess you guys have had a couple presentations on systemic racism and health. I'm probably Johnny come lately here, me and JMag, and you're probably better equipped to quiz me on this. But to us, a motivating question is I don't think we can measure systemic racism in the past, in 1900, but we can measure one component of that, which is racial residential segregation. And there is this argument here. Williams and Collins have been cited about 3,200 times, which is good, that racial residential segregation is not just a cause of racial disparities in health, but a fundamental cause. So kind of harking to some of the fundamental cause theory. If that is the case, how about in the past? Something fundamental should hold. I mean, it's fundamental. Pathways may change, but the relationship would hold. So, I mean, here's a question for you. I don't know the answer, or did not know. I don't think I know it now. Again, was there a relationship in the past? And by the way, this is going to be a fairly descriptive paper. We're asking I think, questions that haven't been asked or answered before, but I think they're important questions. And just note that it's a dramatically different context. It might be different. In particular, causes of death are different than they are today. This is a period where infectious diseases were the leading causes of death, not the diseases of older age as we think about it now. Diarrhea might be a leading cause of death among this population, which is not a cause of death, but a symptom. So the medical data are not great. The residential patterns are much different. I'm going to show it in a minute, but I told you my early perception was there wasn't much racial residential segregation in 1900. And in fact, by the typical measures, there's not. And this, we think, is a holdover from slavery. To manage and supervise your slaves, they had to be close by. And you look across the South, and let's take a city. One historian studied Charlotte, said it's like the salt and pepper pattern of residents. He says you can find blacks and whites in every neighborhood. And by the classic measures of dissimilarity or isolation, they're low. I'll show you some numbers in a little bit. So this is a different context, and maybe play out differently. Housing and sanitation, something like, I'm going to pull this number out of my head, so don't quote me on it. Something like 30–40% of people had access to public water, and a lower percentage had sewage treatment. So these are the ways: it's high airborne infection streams, waterborne pathogens. So very different context in the day. And then we have, of course, very different patterns of discrimination that is overt and legal and sometimes required. So does this relationship between residential segregation and child mortality hold in this dramatically different context? If it does, yes, fundamental cause of racial disparities and mortality. Here's a question. Maybe it's a different relationship completely. And there are some people suggesting it is. That if there is a relationship, is it positive or negative? There are a couple of historians I'll cite in a minute here who say that high levels of segregation in some ways supported Black businesses, and in the daily kind of discrimination you experience day to day in these highly segregated neighborhoods is pretty low, crazily enough. And you support Black businesses, Black labor. These kind of highly segmented markets in some ways may have been helpful. I don't know if I'm buying that, but I'm just saying the argument has been made. And finally, I think you know this, but I'm going to show again, there are large racial disparities and mortality in this period. And of course, they persist over time. And this is the question, do they contribute? Does racial residential segregation contribute to these disparities? Does it help us understand it? So those are the questions we're going to ask. Again, fairly descriptive, and we think we're answering these mostly for the first time. Okay, mostly. There is some prior research. Let me quickly, I'm just going to say 3 areas: mortality, segregation, and the relationship between them. So let's start with the prior research on child mortality. You have to read this book. It's still terrific. 30 years later, Sam Preston and Michael Haynes wrote this book, Fatal Years, Child Mortality in Late 19th Century America. It's based on the 1900 census. We just had a 30-year anniversary at Social Science History Conference a couple of years ago. And there's a special edition of Social Science History coming out on that in a couple months that Martin Dreby and I edited. But it's just still a terrific book that Sam and Mike wrote. It relies on indirect estimation methods. A little bit more about that in just a second here. The first kind of public use sample, the 1900 census, this is a 1 in 750 sample. That meant there was 127,000 individuals, 20,000 households. There's only going to be about 2,000 Black women of childbearing age in the sample. It's going to be really teeny when it comes to looking at race disparities and mortality, but the findings are robust. It's a big book, lots of research, lots of arguments, but let me just go ahead and try to make a what I think is a primary argument here, surprisingly low socioeconomic status differentials in child mortality. One would think that these are, somehow large, that, parents somehow with their money could not buy child survival. There's just not the knowledge or the ability to improve, your child. So as a result, physicians' children are dying at higher rates than farmers' children's, for example, right? And what's important, it's about its exposure. You live in an urban area, you live in a high density areas, you're getting exposed to more infectious diseases, right? So that ends up being critical. And surprisingly, these cultural things, the highest group, child mortality is the French Canadians. Really heavy, really poor in the turn of the 20th century. There are a lot of women in the labor force. And the lowest group is the Jewish population. And we think from cultural attitudes, cleanliness, and these kinds of things that are practiced. By the way, pathways connecting child mortality, it's kind of speculative in this period. So that's a primary finding. How do they measure child mortality? They use the 1900 census, and there is a question. The question comes to every woman who was currently married, or in fact ever married, widowed or divorced. How many children have you given birth to in your lifetime? How many children are still living, right? And so here is Charles Henry and his wife, I'm going to say Emma. They've been married. He's 38, she's 39 years old. They've been married 13 years. She's given birth to 3 children and 2 are still surviving. They're probably right down there, George, Edna, 19th century handwriting, joy. Oh, sorry, it's 20th century. Right? So they've had 1 child that died. And this is pretty typical in the period. Has anybody looked at their ancestors on this census? Just scan that column. It tells you we're living in a different world today than then. So Sam and Mike relied on well, let me go back. The demographic techniques by the United Nations publications, 1980, a lot of work of Sam and other people in developing countries. How can we measure child mortality in places that have incomplete vital registration systems? We ask these kinds of questions, and there are methods associated with it. And basically, they relied on an index for most of their analysis. It's a simple 1, indexed at 1 at some standard life table value. The number of child deaths experienced by the woman relative to an expected number. This is indexed at Model West level 13, which has the Q5, the proportion of children dying before age 5 was about 19%. So that is the standard, yeah. Life expectancy of white population is about high 40s, Black population mid 30s. Yeah. So we have an index based on the number of expected deaths. Here's where things get really interesting. Demography, if you're into this thing, methods. How many expected deaths would a woman aged 38 in a marriage 13 years expect to have? Well, you have to estimate how long the children have been exposed to risk. That requires some measurement of age-specific fertility rates, and to get some kind of sense of exposure to produce the expected. I'm not going to show you the equations. They're complex, but they're simple to implement. And they also produce a mortality reference date, the average date that a woman's children experience the risk of death. And if you think about it as a simple example, let's say you have a 70-year-old woman in the census. She has, 4 children and 2 are still surviving. She had those children probably 35 years ago. Those children were exposed to the risk of dying for 35 years. So half her children are deceased. Now you take a woman who's age 25, has 2 children, 1 is deceased, and the other is living. That woman's children has been exposed to fewer years of risk. So the mortality index for that younger woman should be higher, right? So mortality reference date. Here's some of the results from Preston and Haynes. They have, do I have a little pointer, by the way? Yes. 1895, the white population, that's again Q5, proportion of children dying before age 5. So about 16% of white children were deceased by age 5. 25%, more than a quarter of Black children were deceased before the age of 5. And just to give you a reference from 2019, 0.5%, so very small percentages, right? Black children have 58% higher risk of mortality. Now, the nice thing about a mortality index, you can put it in a regression equation, and you can associate it with a lot of suspected correlates of mortality. And when you do that, and you control for things like mother's age, ethnicity, literacy, labor force participation, father's literacy, occupation, home ownership, unemployment, a lot of socioeconomic variables that are in the census. What's great about this is you can use all these census variables to model child mortality. And then that reduces the differential between Black and white child mortality to about 30%. Why 30%? After controlling for almost everything, seemingly, well, there's probably some variables in the model we're not measuring, right? Housing quality, maybe people in the same occupations made different money incomes if you're Black or white. That would be reasonable to assume. And maybe, for the purpose of this paper, we can consider also the possible contributing role of residential segregation. That's the child mortality part. Any questions about that? Okay, how do we measure segregation? There's the classic ways. You probably are all familiar with dissimilarity indexes and isolation indexes. Typically use city wards. You need 2 levels of geography, a small unit and a large unit, and you can measure dissimilarity or isolation across it. And this can only be done for urban places. Again, something like 10% of the Black population is urban at this point in time. But late 19th century, early 20th century, this is where my earlier perception of very low racial residential segregation comes from. And it's not until the Great Migration that begins from the rural South to the urban North of Blacks, maybe 6 to 10 million, depending on how you want to count. And if you want to count that movement later to the West. But with that movement to the North, you get this rapid increase in racial residential segregation. You've probably seen these kind of graphs before, or hopefully not a surprise. So here, the period we're interested in, somewhat low. Now, at least that was my perception until this recent research came out by, I should have learned how to pronounce these names before I walked in here. You probably know these people. Grigorieva and Royf. Am I getting that close? Anybody know? Martin and Angelina. They took that pattern I mentioned before, enumerators going door to door to door, and where they could in Washington, D.C., started geocoding them, mapping them. And they found what we expected all along, that yeah, the enumerators walking down the street, recording households, right? And what they found was an interesting, what they called a front street, back alley kind of pattern of segregation, where, yeah, maybe there's a low level of dissimilarity index in Washington, D.C. in 1880, but there's massive racial residential segregation within enumeration districts, right? So they developed an index, which we're going to use and apply here. Finally, prior research on historical segregation, mortality, not morality. You know, I told Mary I'd blame her for something before. Mary should have found that. Mortality. There's a classic paper by Yankauer that starts this whole research out. It's really great to read, 1950, looking at New York City's 318 neighborhoods. And what he found was a really strong relationship between percent of the neighborhood that was Black and the child mortality rate for Blacks and white children, right? It doesn't really control for socioeconomic status, but it kind of kicked things off. And second paper, more direct, this piece by Trevon Logan and John Parman that was published a couple of years ago. They use a segregation measure, kind of like the sequential index that they developed in 1880 and try to apply it to cause age at death in North Carolina from 1910 to 1975. I've got some issues with this paper, but it's kind of a cool paper too. And what they find is higher segregation, higher life expectancy for Black men and women. Something I said potentially counter what we were thinking before, which kind of shocked me when I read it. And you know, when you read a shocking result, in a sense, you're always more critical. So I'm a little critical, but I should let it go. Yeah. This one's not. Yes, they in fact do urban rural breakdown, which is great. You know, this is only, the result is only in urban areas. So they find no difference. And my problem with the paper is, of course, you're measuring segregation in 1880 and you're trying to measure an outcome, you know, 100 years later in some cases, right? And it's also when you, this notion of trying to put your arms around a state and you miss all the out migrants. So if someone migrates, let's say there's a thing called a great migration going on, and you lose the out migrants, then you're going to be biasing your age at death. But anyways, it's the only other result and the only other paper published here that suggests a positive, beneficial aspect of segregation for Black men and women in urban areas. All right. How am I doing? Good. So let's get into our data and measures. We're going to use the 1900, 1910 complete count data sets. We're going to have 92 million, 76 million records in 1900, 92, and 1910, but then we take it to the South. The reason we limit ourselves to the South is we're using, there's just too few Blacks in the North. There's 90-some% of the population, and you start trying to measure segregation in places where there aren't many Black individuals was difficult. Okay, child mortality, again, is children ever born, children surviving. Rather than being smart and relying on measures that were, you know, Manual 10 and the United Nations, we had to go and create our own, which has created no trouble, end of trouble with reviewers. But we're going to use a more novel measure because we want it to have better control over our reference period. You know, the sense that women age 70 had, you know, 4 children who were deceased. When were they born? It's just, you can't, you're trying to measure segregation very close to the point child mortality took place. So what we do is we reconstruct mothers' complete birth histories. And let me show you how we do that. So let me imagine, if you will, a mother who's age 48, and she has 8 children ever born, 7 surviving, and co-resident with her in the household. You can see them right there, are kids age 25, 17, 15, 13, and 5, right? Well, there's 5 there, 7 were born, or 8 were born. I'm sorry, 6 were there, co-resident, 8 were born. What happened to the other 2? 1 is clearly deceased, if you do the math. 1's no longer at home. Still alive somewhere, but Lord knows where they are, right? The ones we know that are co-resident, we know the mother's age at birth. So we know her birth history, a partial birth history, if you will, right? We know 6 birth dates of her 8 children, and 2 are unknown, the deceased one and the living non-co-resident child. So what we want to do is we want to probabilistically assign a date of birth to those 2 children. So how do we do that? We start with this partial birth history. We start with the age-specific mortality rate, or fertility rates, excuse me, of women in the birth cohort, women's birth cohort. Standard, you've seen these graphs, right? By the way, it's what they look like in the past in a fairly close to a natural fertility population. And we take the ages we know she has children and we subtract it out of that curve. We notch the curve. We're not going to assign twins. So we're saying that part of the fertility curve, I've seen a couple people nodding their heads, so maybe, you know, I'm not being completely oblique here. So these 2 missing births came from these dark blue areas somewhere, right? That's what we're going to surmise. Where in that area? Well, there's a probability of children dying by age, life tables. That's one part of that risk profile. There's another risk profile if the age children leave home. We can measure that in the census. So with those two probabilities in that space, we can, I'm quite proud of that. What do you think about, should do that again. Yeah. Roll the dice and assign a birth year. And if we do that, in this particular case, the deceased child was put here and the living but non-co-resident, this makes sense, it's probably older child, is assigned there, right? So now, of course, I've got millions. And so when you do this, first of all, you get rid of your computer for a couple of days because it's busy, kind of probabilistically assigning millions of records. But so this might be wrong, right? You do it a million times, you're wrong about a million times, but overall, the general pattern is kind of what you want, right? So we've done that. We've created birth histories. And the nice thing about doing this is now we can do all our analysis on the children born in the 5 years prior to each census. So that problem of potentially, this is of course a time-dependent variable residence that changes. And we want to try to measure things as close to the census as possible. So that's what this woman's complete birth history now looks like. And again, we get millions of these. It's kind of great. Okay, measuring residential segregation. This is Gregorievas and Royce, I'm going to call them. Measure of the sequence index of segregation. This is the formula. I think it's easier just to step through an example to show you here, but it is the number of race-specific runs. I'll tell you what a run is in a minute, over the expected number. It's typically 0 to 1, 1 really high segregation, 0 low. It can, in a few cases, go negative. We're doing this for each enumeration district in the census, and I should talk about enumeration districts real quick. We don't know what they are, really. The census office comes up with them every year, and they don't really talk about them, but you can see them. And where we tried to map them out, they look like neighborhoods with boundaries, railroad tracks, and major roads. They tend to include about 2,000 residents, plus or minus a few thousand. They vary. But it's the smallest geography in the census, and it's available everywhere. So this is the unit we're going to be relying on. Okay, here's a question I'm just anticipating from the floor. Why not rely on more traditional measures of segregation, such as the dissimilarity index? And we did. We measured those things. The problem is you get one number for the whole city, right? We know that mortality in this period varies block to block, place to place. We wanted to include some fixed effects controls because of the geographic patterns of mortality. We wanted a finer grain measure. Now, it ends up the dissimilarity index gets similar results. So I did, yeah. That's right. Yep. Right. Right. Exactly. Same kind of thing. But it has to be the travel path of the enumerator, which are, yeah. Yeah. Now we did compare, you can't compare the same enumeration district, unfortunately, in 1900 and 1910. But yeah, I think they're pretty consistent. So let me just walk you through here what a run is. Let's say we have an enumeration district with 24 houses, and the enumerator starts here and he's walking and he enumerates, let's call white, blue houses and blacks, red houses. 1, 2, he hits all these blue houses in a row, turns the corner, and then the head of household, the race changes. That's the second run, right? Third run, fourth run, fifth run, sixth run, 7 runs. How many is expected with 24 houses in that proportion Black household? You're expecting about 8.91. 7 runs and you run through the equation, we get a SIS of 0.27. This one has 8 runs. We get a slightly high, I'm sorry. It's got, that makes no sense to me. I must have done something wrong here. This number looks bad. And this enumeration district here has just 3 runs. The lowest possible is 2, of course, and has a really high sequence index of segregation. That's kind of the way you step through it. Yeah.
Social organization has the same size, right? It's a single line. So it's not.
Geocode these? Fantastic idea. No was the answer. We need more historical demographers out there. There are people that the geocoding has been done, but in terms of analysis, no. You know, yeah, or your mother-in-law lives right across a street, you know, and the enumerator makes a run on the other side and comes back down the other side. And suddenly she looks like she's 20 houses away and she's just across the street, right? Yeah, there's problems. Again, millions of cases. We have some, we're going to allow some fudge. So one enumeration SIS value for each ED. There are a lot of EDs. There's like 10,000 in the South here. We also look at the proportion of the population that's Black. This is what Zankauer did. And it's kind of let's call it a proxy measure because it's not based on geography in any way. It's just a proportion Black, but we're going to use it and control for it. Okay, let's get into the analytical universe. We are only going to rely on currently married couples because we want the father's occupation. And we're only going to rely on children born in the 5 years prior to each of these 2 censuses. The parents have to have been married for 5 years or more. That's a variable in the census duration of current marriage. And they have to be living in the South. We also, this measurement of SIS is going to require at least 5 white and Black households in each enumeration district. You know, if you have all white households, you just can't quite measure segregation. All right. I'm not going to go through this. By the way, there's a whole paper it's written and we sent it out. Actually, if you want a copy, I'm hacker@umn.edu. But it looks nice. Trust me on this. You know, the things you want to see, the differences you want to see by occupation, by employment, home ownership. Let's just take one at random here. If your parents are literate, one or both are illiterate, you have higher child mortality than if both are literate, about 14% among whites. Blacks have higher child mortality. And also 71% of Black children are born with one child with one parent, at least one parent illiterate, and only 28% with both literate. So you have differences in means as well. So just take my word for that. We did these by cities. Again, only 10% of the population, but it's pretty fascinating. You can get the sequence of index of segregation, dissimilarity indexes, and isolation index, not strongly correlated. I mean, isolation index and dissimilarity are correlated, but the SIS seems to be high in some cities, low in others. Not obvious eyeballing at what we're to expect here. I'm not going to go through all those. We did that for all the cities as well. I do want to point out that when you have a mortality regime that's dominated by infectious disease, you're going to get large spatial differentials in mortality by the disease environment. And here it's malaria, probably, diarrhea again. This is the white population. You know, maybe it's one of these tests where you see patterns that really aren't there, but I see higher child mortality along the Mississippi River and Red River, kind of these low-lying malarial grounds. And there's the Black population, much higher mortality. You still have these same, we have pretty strong correlation. And I mean, they're very different, but correlation across counties between white and Black mortality. Because of these kinds of patterns, we were very worried of just say, comparing the, dissimilarity index. By the way, we do have Baltimore. That's with Atlanta, for example, right? Without doing some type of geographic fixed effects on our regression models. So, from this, we take away the notion that we have to do some kind of geographic controls. All right, this is all going to come to a conclusion very quickly because we're using logistic regression. Our dependent variable is whether these children born in the 5 years prior to the census are alive or dead at the time of the census. So this is period 1895 to 1900. Now, of course, a child born in 1895 has 5 years to die. Child born in 1899 only 1. But we're just we're controlling for the age of the child, birth year for the child. The variables of interest is proportion of the population Black in each enumeration district, the sequence index of segregation, and we also do interaction of those two variables by race, thinking that maybe segregation has a different impact on Black children than it does on white children. We control for everything possible here. So we're trying to control for as much as socioeconomic status as possible. I should have said, this whole literature on racial residential segregation, child mortality, a lot of that filters through socioeconomic status because people growing up in impoverished neighborhoods have, poor work opportunities, all kinds of, but some of it seems to be independent as well. So we're trying to control for socioeconomic status, and we use county level fixed effects. These are odds ratios, easy to interpret. So in this case, first of all, I'm going to show you that there are models for rural areas. I'm showing you 1910 only. 1900, very similar results, which makes us happy. You get, so I'm just going to show you 1910. So these two models for rural areas, these two regression models for urban areas. And the first model, our idea is we're doing a baseline model where we want to control for everything without our segregation measures. In the second model, we're going to introduce our segregation measures to see what changes. So, so the first model here, you're going to see Black children, all things being equal, that we can control for. This is about the same as Preston and Haynes, 30%, 32% higher child mortality among Blacks relative to the white children. And in urban areas, it's massive. This is also true in Preston and Haynes. 80%, 78% higher child mortality among Black children in urban areas of the South than white children in those areas. I'm looking at these coefficients right here, that and that one, right? Okay, let's look at the models where we add our segregation measures. First of all, proportion of population in the enumeration district that was Black is positively correlated with mortality. If you live in a neighborhood with a higher proportion of Blacks, your child suffers a higher rate of death. All else being equal. The interaction effect, it's even more so for Black children, kind of an incremental in a sense. So the interaction of growing up in a high Black neighborhood, this is the opposite of what I was suggesting as a possibility. This is kind of confirming kind of fundamental cause theory here. The sequence index of segregation, interestingly enough, has no impact for white children. No effect. I shouldn't say impact. These are correlations. I'm sorry. But is positively correlated with the mortality of Black children. So a nice result. By the way, there's about 2 million children in this model, living in 11,000 enumeration districts, about 1,200 counties. All right. Looking at the urban models, similar results. This does not proportion Black and the ED is not significant for white and Black children combined by itself, but the interaction term is again positive for Black children and highly positive. So positive meaning correlated with mortality, not good. Right. The sequence index of segregation here that's below 1, the odds ratio, but the interaction with Black children is again positive, above 1. We're thrilled with these results, kind of what we're thinking we might see. Looking at this unexplained, it is, race differential in mortality. Once we add mortality or the segregation variables to the model, we see a reduction of about 15% in the size of that coefficient. So we are helping to explain some, not most or not all, but some significant proportion of that discrepancy between white and Black mortality. And here, about 13% in the urban models. Questions about that? That's a lot of coefficients in a short period of time, yeah.
So, saying that there's a mortality penalty for Black children are highly, like
yes, I think you're getting there. No, they're highly isolated, and it's a high sequence of index of segregation. So you got very few racial runs, and right. We don't know that, but we are controlling, of course, for proportion Black, right, is in the model, and the interaction terms as well. It's a great question, and you interpret it just the way I wanted you to. So maybe I'm making some sense up here. Sometimes you stand up here. I don't know if you're making any sense. Anything else about this? All right, let me get to some conclusions, and I'll give you some time here. We ran baseline models without segregation variables, and this is no surprise to anybody. Black children are much more likely to experience child mortality than white children, especially in those urban areas, even after controlling for all the things we can control for in these models. This variable resident, and again, this is kind of a proxy measure. It's not based on exact geography, but proportion Black in the ED is positively correlated with the mortality of Black and white children in most models, while the sequence index of segregation is only positively correlated with Black child mortality. And that, depending on, if you look at 1900 as well, which I didn't show you, we can explain some 10 to 22% of the race differentials in mortality. I think, and you can push back on this, these results kind of support the hypothesis that racial residential segregation is a fundamental cause of race disparities in mortality, right? And more generally, systemic racism. We need to geocode some data. I mean, obviously, I know that. And there are some efforts going on by John Logan and others to geocode some of these places that have addresses, but we'll probably never get much. We need to perhaps do some of the work that I talked about with the linked data sets. And maybe we can speculate about causal pathways. You might have noticed that missing in your talk, but in the talk, because I'm a little uncomfortable with that now with these kind of historical data sets. But obviously, airborne, waterborne pathogens are what's taking a toll here. And crowded housing, tuberculosis, bad environments are obviously playing a role here. Okay, so this has been funded. So acknowledge our funders, and I will open the floor to questions. Yeah.
Very important. We have the primary cause of mortality. So, trying to kind of isolate sample you're speculating because it's causal things like that.
Yeah.
curious if that's something that you can do.
I'd love to, but we don't have ED maps. We don't know the size of these areas, especially in rural areas. So we do have, of course, I didn't show it in the models, but we do have controls for different sizes of cities, but that's not density. You're absolutely right. That should be a key variable that should be in these models. But until we have GIS boundaries of these things, we can't measure population density. I mean, I may be able to do something at city level, but it's a real gap in the historical record. So put your finger right on it. Thank you. Yeah. Next. Yeah. That's okay. Three things. First of all, I don't know the sex of the child that died. I'm imputing a death date. So I could go ahead to that extra step. I was actually for a while imputing a death date too. And I realized when you impute birth and then impute a death, you're nowhere land at that point. So I can't do anything with the gender. With the linked data set that I could, right? The nonlinearity is it's a great suggestion. We do control, as I said, for the age of the child, and the parity. I can't even remember the results now. It's been a while since we ran it. I think was weakly positively correlated with child mortality, if I remember right. But you have these really large families, and it could be lack of care. It could be crowding of households. It's hard to know. The other possibility density measure is like the persons per household. As someone has suggested, it might be a good idea for a control. Yeah. Thank you, Jason. Yeah.
Curious about how important when you talk about well, I guess how talk about only looking at those with very public. And I can see that being impactful as a division. Not that there's mortality differences vary for single parents, married families.
They do. They do. Yeah.
I think that's two that that's not an interest in the population that people that single parents are a portion of born and three that they're favorable in single parent families. And again, I don't know enough historical demography to know those two different exactly in the period. So I'm just giving you comments about how you thought about that, or if it matters. One doing include only areas families who father occupation like that.
Yeah.
Include father occupation, exclude them to resolve.
Yeah, great questions. For not knowing historical demography, you asked great questions. They're right on it. Absolutely, that a single mother, it has to be a mother survives, because we won't get the data, of course, right? Have higher child mortality rates. We know that, and we can impute birth dates of child, and I've done it, but I'm a little more nervous about that because we don't know how long when she was married. So there's a variable duration of current marital status, but so I'm trying to impute a birth of a child that maybe is deceased, and it's probably further back in the past because her husband's not here now, right? So that can go into the model the probabilistic model when I roll the dice, and I've tried to do that, but I'm a lot more nervous about that imputed birth date first. And the occupation was so important in terms of our control strategy. I mean, really, it's just one of the stronger variables, but you're probably right. I should run this kind of as an appendix or some kind of sensitivity analysis, but absolutely. And in fact, it's going to, the paper I was thinking about presenting to this workshop when I changed my mind last minute was using couples who stay married over a decade to try to measure child mortality based on their surviving children from the first linked census to the second. And that's especially a problem there because we need both parents to be there to make sure we're sure of the link, but we're going to underestimate child mortality as a result of that. How much? I mean, here's the joy of historical demography. I mean, it's like we're shooting hand grenades a little bit. We get these big effects. We're pretty confident with these things, but yeah, there's by the way, a lot of single parent households in the Black population relative to the white population, and there's even higher child mortality there. So these high differences are among currently married couples, which says something. Yeah. There's some aggregate stuff, right? Yeah. For white mothers, we think it's about 50-50 around the turn of the century. For Black mothers, 90-10. 90 at home, 10% else. And I don't know how to operationalize that into a test or how much it matters, but you're absolutely right in a sense that until really sulfa drugs in the 1930s and 40s, these hospitals had higher maternal mortality rates than home births, because the physicians were going from woman to woman and spreading, the puerperal fever and other types of infections. So it's a cool idea. Yeah. Yeah. Yeah.
In overall terms, how are the all there was a practical for being close. Is there a way to the population side to it's all
Yeah. Right. I mean, there are these tenement housing and ghettos, and there are these high density areas, and it does vary. And housing quality absolutely as well. What I've seen among other scholars trying to geocode things is water supply lines and sewage lines, and there's attempts to do that, which is really fascinating. And even lead pipes with water supplies, and linking those kinds of residential effects that we can follow in later life. And that's a pitch I should have made for historical demography. I know many of you in the room might be interested, hopefully, in early life conditions, neighborhood effects in later life, which kind of makes you historians by default. So if you're interested in studying the present, you need to go back 70, 80 years in some cases. But yeah, I wish. There's a lot of things I wish here. But let me point out the good is we got great child mortality data over millions of birth histories. Yeah.
So erring on the side of like umbrella from there just think about is it just makes this intuitively sense to me before you even got into the schematics, because really redlining is just a formalization of the segregation that already exists. Yeah. It's really just formalizing an exactly setting up that we are there that we got to do. And so I just sort of like put this back into process of redlining. How was it decided was became a district decided to get the process of rating. And so it seems like I might know more, but it seems like the pattern is consistent. It's more likely that we're going to see redlining happening cycle in urban areas.
Absolutely.
So back into the population density, and just think about like the birth frequency and whether that's accurate assumption, whether that's urban area versus rural.
Oh, that part.
That as like a proxy for sort of like population density and geocoding in account, and whether or not it's realistically have enough data to compare it to urban areas versus rural areas, and what extent you can out of here.
Yeah.
And whether the number of children having
That's an interesting idea. I'm going to have to.
There's like a lot.
I don't know. I don't want to answer it on the cuff. here. I do want to say there's a lot of great work going on with redlining neighborhoods and in a number of places right now. Mostly, of course, later than this period, 1930s, 20s, 30s, and man, for me that's current events, and I'm a little nervous about answering that. But I don't know. Sometimes you go give a talk and somebody makes a comment. I think I'm gonna go take that one home and think about it. Yeah. Yeah. Right. Yeah. But of course, we're finding these same things in this SIS indicator, similar relationship, rural and urban areas, and most of the action, again, 90% of it in the South is in the rural areas. Wow, you could just use the X-score variable, and you could run. Right. That's cool. I mean, there's also geographic. We got everything. We can start producing aggregate statistics on, let's say, local neighborhood income things, not just runs, but the runs I've never thought of. It was a fascinating idea. But you can aggregate at the ED, county, city, ward levels, different things like percent farmers or whatever you want in rural districts, or sharecroppers in the South. There are a lot of things one can produce as a contextual measure, and we're getting pushed a little bit by reviewers on that. But that's an interesting idea. I'll put that down in my take it home. Well, Christine.
You have county, and I guess I was also in the story and how there's these places like water, and I guess I wonder, and what you end up having.
Yes, that's right. Across EDs. Oh, that's, yeah. Right. To get at some kind of sense of waterborne, airborne kind of thing. We also have these malarial counties that were identified by the Rockefeller Institution, and you could maybe do some. This is one of the problems here. We're going to run into many things we could interact, but that one's a great one idea. But I should have said I'm not taking any suggestions now because I just sent the paper out. But that's yeah. I'm getting a couple of great ideas. I'm thrilled. So thank you. I think we're there. Thank you guys for your time.